After we finish the examination of this patient, now for the inspection, palpation, percussion, auscultation, lymph node. And after that, we go to the end of the examination. Okay, and to present your finding and tell the patient to shake your hand as I mentioned before. Cover the patient, hand sterilization, present your finding, and if you'd like to do another test, you can tell the examiner, say, I'd like to examine other lymph node, I'd like to examine the hernia orifice, I'd like to check for hypertension, for diabetes, check urine analysis, like this. If it is relevant or if you would like to okay. Let's go to the other common examiner question, as I mentioned before. Present your finding. What's your finding? What is your differential diagnosis? What's your diagnosis first? What's your differential diagnosis? And what is the plan of management, including investigation and the treatment? This is a clinical judgment, and as long as you maintain the patient welfare, it will be very good. Let's go to start by the kidney size firstly, then we did the last time the last part for the liver and spleen and lymph nodes. Regarding the transplanted kidney, any case of transplant, you feel that you have a scar at the right lower quadrant area, okay, or right iliac region. This scar, you need to check that there is a mass below this scar. You can identify the size of the mass, the size, the not tender, palpable, not attached to the skin, about, for example, 5 centimeter by 3 centimeter, like this. So comment on this transplanted area mass by mentioning that you see the right lower quadrant mass with above it there is a scar, and there is about 5 by 8 centimeter. There is a regular smooth surface, not easy mobile, and auscultate the mass. There is no any audible bruit or any abnormal auscultation on the mass. Okay. Then now you aware, but that by that this case is a case of transplanted kidney. You need to check what is the current mode of renal replacement therapy. Now is a transplantation. Previous mode, search for any scar of the abdomen for any previous Tinkoff catheter. Search for any scar in the neck for previous pericocet session. Search for any AV fistula in the arm or any graft in the arm indicates that the patient was on regular hemodialysis before. Checking the volume status of the patient, if this patient is euvolemic or hypervolemic, and try to search for a cause of renal failure if it's apparently to you. Okay. If it is not apparent, you will mention as a differential diagnosis the cause of renal failure will be diabetes, will be polycystic kidney disease, will be renovascular disease, will be hypertension, will be drug induced, will be idiopathic. Okay. For differential diagnosis regarding the causes of interstitial disease. Okay. So we have evidence of interstitial disease in this patient. We have evidence of current mode of renal replacement therapy, which is a transplantation. We have evidence of previous mode of renal replacement therapy, either hemodialysis or peritoneal dialysis. Hemodialysis search for AV fistula or hemodialysis catheter. Peritoneal dialysis search for Tinkoff catheter or scar of previous peritoneal catheter. Checking the volume status of the patient by the GPD, lower limb, if there's lower limb edema or no, and the auscultation of the back of the chest to indicate that the patient has no lung congestion or lung overdose. The adequacy of dialysis is maintained or no, and this patient not have any itching, no uremic manifestation like this. And if this patient has a transplantation, search for the complication of medication of transplantation, the immunosuppressive medication. For example, the most famous, this patient taking steroid, no Cushingoid phase, No any. What about tremors? What about gums hypertrophy? Okay. This is for case of renal patient with renal transplantation. So full comment about the kidney transplant, full comment about the items as we mentioned before. And then after that, you will be asked or you will need to know what is the following. Maybe you will be asked about the causes of mass in the differential diagnosis of this mass. So you have now mass at the right iliac region. What is the differential diagnosis of mass at the right iliac region? Okay. Anyone has a suggestion? Differential diagnosis of mass at the right iliac.
Inflammatory mass, Crohn's or
Crohn's. Good.
Yeah. Maybe pelvic mass.
Pelvic mass, yes. Ovarian mass. Or this mass is a transplanted kidney, or it can be ectopic kidney. So transplanted kidney, ectopic kidney, ovarian mass, appendicular mass, cancer, carcinoid, if it's come in the iliac region, TB, and lymphoma. This is the differential diagnosis of the right lower quadrant mass. The same is differential diagnosis for the left iliac mass is the same also. It may be transplanted kidney, but the usual site is the right side. It can be ectopic kidney. It can be ovarian mass. Appendix only in the right side, cannot be appendicular mass. The cancer colon can be cancer colon. Okay, so this is it can be fecal induction. So this is the main differential diagnosis in the right iliac fossa: transplanted kidney, pelvic kidney, ovarian mass, appendicular mass, cancer colon or Crohn's, or carcinoid, TB, lymphoma. Okay, so on the left side, the same: transplanted kidney, pelvic kidney, ovarian mass, or cancer colon, or fecal induction. Right. For the carcinoid syndrome, as you know, it's characterized by the famous triad of flushing and diarrhea and wheezy chest. And it is one of the interior, what's called neuroendocrine tumor. Usually, it can come from the iliac region, and it go to the liver and make a metastasis in the liver before the classical symptom can be apparent. So, and it's one of the causes of enlarged hepatomegaly. Okay, is the carcinoid syndrome, and it's famous characterized in the history or in the taken history by the triad of flushing, diarrhea, and wheezes. What is the investigations of carcinoid? What is the treatment of the carcinoid? Question. If you would like to share or to make brainstorming. Investigations of carcinoid.
Serum chromogranin 5
Serum.
HA.
Serum chromogranin.
Urinary 5-hydroxyindole acetic acid.
5-hydroxyindole acetic acid in the urine is elevated, and the serum chromogranin is elevated. Yes, exactly. And the other mode of investigation is what's called octreotide scintigraphy scan. This is very specific and very sensitive, and the gold standard method of diagnosis is the octreotide scintigraphy scan, and it predicts the degree of response of this patient to octreotide. Okay? The treatment of carcinoid syndrome is by somatostatin, cryptopeptidine, and surgical radiotherapy chemotherapy. Okay? This is a treatment of carcinoid syndrome. Just I'd like to remind you about that. With after transplanted kidney, you can see a polycystic kidney. Okay, polycystic kidney disease is patient has enlarged loin allotment. You can see allotment in kidney. You can see this patient has bilateral because mostly they have secondary polycythemia. Polycystic kidney disease, as you know, one of the causes of end-stage renal disease. You can see that this patient bilateral flank mass, and there is a ballotment of the kidney on the right side or on the left side. Is very characteristic to differentiate it between the kidney and the spleen. Okay, to differentiate a mass of left side, especially left side, is it spleen or the kidney? There is some differential diagnosis. Ballotment, the kidney is the only palatable organ. This is number one, by ballotment. Number two, by a change of breathing. If this patient take inspiration, usually inspiration will push the diaphragm, so it will push the spleen because the spleen is below the diaphragm. But in case of the kidney, no affection of the inspiration. The third point is you cannot insinuate or reach to the upper border of the spleen because it is below in the costal margin. You cannot insinuate your hand between the spleen and the costal margin, but in the kidney you can feel the upper border of the kidney. And if you do percussion note, the percussion note over the kidney will be resonant because the kidney is retroperitoneum and the intestinal lumens is in front of it. But spleen, the percussion of spleen usually dullness. Okay, this is the main 4 items for differentiating between spleen and the kidney. Okay, search for this patient if he has symptoms of intestinal disease. Okay, if he has a uremic symptom, if the patient has volume overload, if the patient has current renal replacement therapy, maybe he has polycystic kidney and started to have intestinal disease and he is now has ongoing dialysis. So search for AV fistula, search for vermicase catheter, okay, in the neck. If any previous renal replacement therapy before, he has hemodialysis before or renal transplantation before and failed, any scar in the abdomen for indicating that they have renal transplantation before. And you can offer, I'd like to examine the blood pressure for this patient, and for checking the blood pressure, and I'd like to examine the heart because you know the associations between polycystic kidney disease. This patient usually have hypertension. They have an valvular heart disease, especially mitral valve prolapse, mitral regurgitation, aortic regurgitation. They might have also neurological manifestation in the form of ruptures of the aneurysm in the brain, cerebral aneurysm, liable to be ruptured, and this patient will develop a subarachnoid hemorrhage. Okay, and they can have a stroke or neurological insult after that. This is regarding the polycystic kidney disease. Okay. To remind you, the 4 items to differentiate between renal and spleen. Okay. By percussion note, breathing effect, palpate above, and ballotment. 4 B's. Okay. Percussion note over the spleen is dull, over the kidney is resonant due to the intestinal around or will be present overlying the kidney resonant due to the overlying bowel because the kidney is retroperitoneum, so the bowel is overlying the kidney. Movement with breathing, the downward of the diaphragm will help to detect the spleen, but will not help to detect the kidney. Okay, palpate above, you cannot palpate above and reach the upper border of the spleen. Palatable, the kidney is the only palatable organ in the abdomen. Okay, this is regarding the difference between spleen and the kidney. Right. Let's go to the differential diagnosis of palpable kidney. If you have palpable kidney, okay, single or bilateral palpable kidney. Single palpable kidney, it means that you have an enlarged kidney. Mostly it's either polycystic kidney disease, or due to hydronephrosis, or due to renal cell carcinoma, or due to hypertrophy, as it is a single kidney and the other kidney is missed by operation or trauma or anything else. Okay, so this is 4 differential diagnosis of single palpable kidney. For bilateral palpable kidney, this may be bilateral renal cyst or bilateral hydronephrosis or bilateral renal cell carcinoma, or amyloidosis. Okay. In bilateral renal cell carcinoma, this is the characteristic of von Webel-Lindau syndrome. Okay. This will give you, will let us to discuss what's called differential diagnosis of bilateral renal cysts. Bilateral renal cyst. So if you have a patient with polycystic kidney disease, what's the differential diagnosis of polycystic kidney? It may be simple cyst, which is a benign condition. It may be autosomal dominant polycystic kidney disease, or autosomal recessive polycystic kidney disease, or other syndromes which also characterized by having a polycystic kidney, like tuberous sclerosis, because it's carried also by the same chromosome of the polycystic kidney. Okay. Von Webel-Lindau syndrome, Lawrence-Moon Biebel syndrome, trisomies the number 13, 18, 21. Okay. So if you ask about differential diagnosis of single palpable kidney or differential diagnosis of bilateral palpable kidney, in bilateral palpable kidney will include that you have a bilateral renal cyst, or bilateral hydronephrosis, or bilateral renal cell carcinoma, or amyloidosis. And bilateral renal cyst is also for another differential diagnosis if you would like to differentiate multiple cysts in the kidney for differential diagnosis. Okay. So this is a differential diagnosis of bilateral renal cyst. Right. Let's go to what is the investigation of a patient with a polycystic kidney disease. Do you have any suggestion or would like to share or would like to? Investigation of polycystic kidney disease. Firstly, do investigation like all other kidney disease. You are doing complete blood count, urea electrolyte, venous blood gases to detect any metabolic acidosis, to detect any hyperkalemia. Doing abdominal ultrasound to check the side of the kidney, to check any obstruction, any hydronephrosis, any hydroureter, any infection, in any retention or infection, repeated infection of the cyst, because this patient liable for repeated infection or rupture of the cyst, so that they have loin pain like this. So investigation like any other kidney disease, and investigations for detection of the complications. We have three main complications: either associated cyst, or the brain due to intracerebral aneurysm, or to check the heart affection of the polycystic kidney disease. Associated cyst, as the name indicates, polycystic kidney disease, it's usually associated with some cyst in the liver, or in the pancreas, or in the spleen. Mostly in the liver, about 70% of the cases of polycystic kidney disease, they have a liver cyst. Okay, and 10% have pancreatic cyst, and 5% have a splenic cyst. So to search for other associated cysts in the body. You have another disease, what's called autosomal dominant polycystic liver disease. This is another separate disorder. It is not associated with any kidney cyst or any cerebellar aneurysm. But the autosomal, the polycystic kidney disease, it can be associated with liver cyst, as we mentioned here, by 70% of the cases. This is first complication. Second complication is the brain, because this patient liable to have an intracerebral aneurysm, and this intracerebral aneurysm is liable to be ruptured, and it will develop subarachnoid hemorrhage. Okay, we need to screen of this by CT cerebral angiography, or by MRI angiography, MRA I mean. So CT cerebral angiography or MR angiography, but this is usually not done as a routine for all cases. It is usually done in cases with a positive family history of the same condition. And for sure, if you have something like this, you would refer to the neurosurgical team. Okay. The third issue is heart checking of the heart for associated valvular lesion like mitral regurgitation, mitral valve collapse, aortic regurgitation, checking for the left ventricular, any left ventricular hypertrophy or concentric left ventricular hypertrophy due to hypertension, which is a common complication of patients with polycystic kidney disease. So this is the second investigation is for the complications. The third one is very, very important, is to advise this patient for screening for the family member. Okay, it's very important by ultrasound, simple method, especially at the age of 20. So if you have one person in front of you now and you have diagnosed him or her as a polycystic kidney disease, you need to advise him regarding the inheritance of the disease and ask him to bring all his sisters and brothers to do screening. Okay. And the screening is by ultrasound at the age of 20. This is according to the guidelines. Okay. After investigations, we'll go to the treatment or management. What is the management of patient with polycystic kidney disease? Management of polycystic kidney disease is sometimes this patient coming with acute abdominal pain, with acute loin pain due to infection of the cyst or due to rupture of the cyst. Because this polycystic kidney, the cysts are not communicating with each other. They are not communicating with the drainage system of the kidney. So each cyst liable to be distended by and then liable for infection and liable for rupture. So if the patient comes with a flank loin pain, he need to receive analgesia, and if there is infection, give the patient antibiotic. Number two, the patient with polycystic kidney disease can be titled as any patient with chronic kidney disease. So management of this patient as any patient with chronic kidney disease for control of blood pressure, for giving the phosphate binder if he has a hyperphosphatemia, for support the bone of this patient by giving vitamin D, monitor the parathyroid hormone if this patient needs calcium mimetic or need parathyroidectomy, and consider the renal replacement therapy in this patient if indicated, okay, for hemodialysis or for renal replacement therapy by renal transplantation. And the last item is the screening. Don't forget to mention this. Screening is very important regarding the family member of the patient at the age of 20 by ultrasound. And you can need to do a nephrectomy for this patient if the some situation, if the patient has large size of the kidney, or he has repeated infection or repeated stone formation, or he has need to do transplantation of this patient and you would like to make a space for renal transplantation. So in case persistent pain or recurrent perinephritis or recurrent stone formation, or to obtain a space for renal transplantation. Okay, let's go to another topic, which is complication of polycystic kidney disease. What are the complications of polycystic kidney disease? We mentioned some of them now. If you would like to, would you like to participate to share? Okay. Dr. Richie, Dr. North, Dr. Had.
Hello. Hello. Yeah. What is the question?
Complications of polycystic kidney disease, yes.
Maybe infection or hemorrhage.
Yes, recurrent infection.
Stone formation.
Recurrent stone formation, yes. They can develop end-stage
Subarachnoid hemorrhage.
Yes, subarachnoid hemorrhage due to rupture of the cerebral aneurysm, hypertension, and affection of the heart. Yes, for the palpable heart.
Sorry, renal cell carcinoma.
Renal cell carcinoma, I am not sure. They are liable to renal cell carcinoma or no, I'm not sure. The von Hippel-Lindau syndrome is polycystic, doing a polycystic kidney and renal cell carcinoma. But polycystic kidney disease, I'm not sure.
And if large kidney, then intestinal obstruction or something.
Sorry, intestinal obstruction of what?
If it is very large kidney, then compartments are more there.
Yeah. Okay. So you can have end-stage renal disease Okay, 60% reach this by at the age of 60 years old. Ruptures of cerebral aneurysm leading to subarachnoid hemorrhage. Recurrent infection, as you mentioned, because the cysts are not connected with each other, as I mentioned before, so that they have some develop a renal stone, renal infection, renal pain like this, hypertension, secondary polycythemia, and the heart affection for the valvular lesion, especially the mitral valve collapse, mitral regurgitation, aortic regurgitation. Okay. These are the complications of polycystic kidney disease. Let's go to what is the investigations you need to do for any patient who has renal failure. Okay, like
basically we have to see what is the potassium level, what is the ABG, that patient, creatinine, urea, CBC for anemia,
yes,
and then calcium phosphate,
parathyroid hormone, yes,
urine routine, ultrasound abdomen, urine, and renal Doppler.
yes, urine
And
analysis and urine protein. Okay, and kidney ultrasound and the kidney Doppler. Yes,
Doppler.
great. Okay. And finally, we can do renal biopsy if we don't reach to a diagnosis. And also the autoimmune markers also can be considered, like ANA, DNA, ANCA-C, ANCA-D, anti-glomerular basement antibody. Okay. So yes, as you mentioned, urea electrolytes, including the potassium, is very important. Venous blood gases to rule out any metabolic acidosis. Examine the urine, very important for urine analysis in infection. Urinary albumin creatine ratio for proteinuria to the microalbuminuria or macroalbuminuria. 24-hour renal protein if you have macroalbuminuria by urinary albumin creatine ratio, macroalbuminuria above 300, and you would like to estimate if did you reach to nephrotic range or no. Nephrotic range is 3 grams. So you will collect the 24-hour renal protein for this patient to know if you are in a subgroup of nephrotic range proteinuria or subnephrotic range proteinuria. And the some marker of chronicity, if you have any patient with renal failure or increase in elevated serum creatinine, you would like to know if it's acute or chronic. You can, by the test, you can give you a clue. If the patient has anemia, this indicates that this is chronic kidney disease rather than acute. If the patient has hypocalcemia or hyperphosphatemia or hyperparathyroidism, this indicates that this is a long term, matching more with the chronic kidney disease. The autoimmune marker is very, very important to like ANA, like extractable nuclear antigen, double-stranded DNA, ANCA-B, ANCA-C, C3, C4, anti-glomerular basement antibody, cryoglobulin, like this. Okay. CBK is very important, like in patient has a marathon or running or young athletes like this, they have a rhabdomyolysis. Infection screen to rule out any infection by doing infection screen for antitetricin or tetr maybe post-infectious glomerulitis, maybe patient has malaria, do blood culture, rule out infective endocarditis. Okay? And as I mentioned, Dr. Richie, the image ultrasound of the kidney, renal duplex to rule out renal artery stenosis, and finally the kidney biopsy. Okay? If you have a patient with renal transplantation, okay, so you have renal transplantation and you would like to do what is the investigations for a case of renal transplantation. So the same also, we will start by doing lab test in the form of CBC, okay, urea electrolyte, blood gases, checking the blood sugar, and checking the blood level of these immunosuppressive medications, okay. Usually the medications like tacrolimus and cyclosporin, they are induced to induce diabetes. Okay? This tacrolimus induced diabetes, cyclosporin induced diabetes. Also steroid induce diabetes, so you need to check the blood sugar for this patient regularly, and drug level of tacrolimus and cyclosporin to monitor it. Okay. After that, test for opportunistic infection for this patient, especially the CMV ذا بوركيلو فيروس بايلوما فيروس البي كي اللي هو بايلوما فيروس باي بي سي ار and the immunocytes carcinoid pneumonia or the new name is the immunocytes jirovecii pneumonia by bronchoalveolar lavage they have respiratory syndrome. And lastly, the radiological investigations, the form of duplex on the graft, first ultrasound on the graft, duplex on the graft, and you can take graft biopsy. Okay. If you have unexplained renal impairment in the patient with transplantation. So this is a summary of investigation in renal transplantation. What is the differential diagnosis or causes of graft tenderness or graft dysfunction?
Means any infection, any thrombosis of the
Thrombosis for the graft, yes.
And second is infection of the graft and rejection of the graft.
Infection and rejection. Yes. Yes. Very excellent. Very excellent. Yes, thank you. So maybe graft rejection or graft infection or graft thrombosis. Okay. What are the complications of renal replacement therapy? So you have now a patient, you finish to examine the case, and this patient has end-stage renal disease on regular hemodialysis, or end-stage renal disease on continuous ambulatory peritoneal dialysis, or this patient has a transplanted kidney. So what is the complications expected to come to this patient?
In transplantation,
we can classify it: complications for hemodialysis, complications for peritoneal dialysis, complications for transplanted kidney. Okay. Complications for hemodialysis. Firstly, the lifestyle. So this patient need to come to the hospital about 3 times per week, and each session will be 4 hours. Okay. So 12 hours dialysis sessions per week over 3 times per day. Each session is 4 hours. So lifestyle intolerance is number 1. The first after that is the cardiovascular complication. The cardiovascular complication is the first top complications in patient with hemodialysis. Okay. Number 2, this patient has a vascular access, so some complication related to the vascular access, failure of the access, infection. Maybe he has a fistula, maybe he has a vermicast kinking fever in the catheterized patient, like this. Okay. And what's called beta 2 microglobin amyloidosis, which will lead to the carpal tunnel syndrome and amyloid arthropathy. Plus also the bone mineral disorders, which is associated with the renal patient on hemodialysis. What about complications of peritoneal dialysis? You can expect that by patient now insert a catheter inside the abdomen. So firstly, he has a problem related to this catheter. This think of catheter problem, kinking, infection, damage, malfunction like this. This is number 1. Number 2, peritonitis. It's very, very common. 50% of the patient, they will suffer from peritonitis. Peritoneal membrane dysfunction. EBS, which is encapsulated peritoneal sclerosis. This patient may liable for hernia, especially the umbilical hernia, malnutrition due to protein loss, and diabetes due to the glucose content of the dialysis. Regarding the complications of renal transplantation, maybe rejection, maybe recurrence of the original kidney disease, maybe structure related after this renal transplantation. Because renal transplant, you connect the artery with the artery, the vein with the vein, the ureter with the bladder. So maybe renal artery stenosis, maybe renal vein stenosis, venous thrombosis, maybe the ureteric leakage or restriction of the ureteric pathway, and for sure the complications of the medication, immunosuppressive complication. Okay. So usually you can face this important topic regarding complication of this patient, why he has renal transplant, or complication of a patient on hemodialysis. Okay. Immunosuppressive medications the side effect. I will mention that later in another slide, but generally, usually this patient is liable for infection, recurrent infection, opportunistic infection, diabetes, hypertension due to the steroid and tacrolimus and the medications of immunosuppressants like tacrolimus and cyclosporin and steroid. Malignancy, this patient is liable for basal cell carcinoma, squamous cell carcinoma, and what's called post-transplant lymphoproliferative disorder. Okay. So if you ask it to what is the importance of examining the lymph node of this patient, the patient is transplant, so to check for the PTLD, post-transplant lymphoproliferative disorder. Right. Let's go to another questions, which is what is the causes of renal transplantation in this patient? Or by another mean, what is the underlying etiology of end-stage renal disease of this patient? Upon it, this patient was doing the renal transplantation as a renal replacement therapy. The underlying cause of end-stage renal disease by the frequency or by this patient. So the differential diagnosis, if you would like by frequency, what the most common cause of end-stage renal disease is the diabetes mellitus, okay, followed by the glomerulonephritis, followed by the renovascular diseases like arterial stenosis, etc., followed by pyelonephritis and recurrent infection and reflux disease, followed by hypertension, followed by autosomal polycystic kidney disease, followed by other causes like, for example, drug-induced and nephrotoxic medication, interstitial nephritis, like this, and there is remaining unknown causes about 26%. So this is the 9 causes of end-stage renal disease. Any patient has end-stage renal disease, he will be under category of these 8 items. If you have a patient and you would like to know, so you can check by this order of the frequency, or you can check if you have a clue in front of you, so you can reach for a differential diagnosis. If this patient has a glucometer, so he is diabetic, he has prick needle of the checking blood sugar, so this is mostly for the diabetes. If this patient has young and repeated urinary tract infection and he has cycloreteric reflux like this, so mostly this is due to repeated pyelonephritis. If this patient has repeated stone formation and obstructive uropathy like this, maybe this is the cause. If this patient has a polycystic kidney, or this is the cause, or this search for a drug induced, or this patient, for example, have an other autoimmune feature, making a feature of systemic lupus erythematosus, for example, or any cause of glomerulonephritis, or having ear aid, so can think about Albert syndrome, etc. Okay. Right. Let's go to another common question regarding what is the immunosuppressant medication used for renal transplantation. Usually, the renal transplanted patients, they use the main important immunosuppressants are the coming 4 categories. Number 1 is the steroids, especially the prednisolone. Number 2, the calcineurin inhibitors, which are the cyclosporin or tacrolimus. And this is the trade name. This is the scientific name, cyclosporin. The trade name is Sandimmune. Tacrolimus, the trade name is Prograf.